So if you start to have upper respiratory tract symptoms like a sore throat, headache, maybe a stuffy nose, although that's less likely, and you do not smell or taste well, you probably have COVID-19. Be productive. Create something meaningful. Reach out to friends you haven't talked to in a while. Anything to distract yourself from thinking about COVID-19. We are going to get through this. Pandemics happen in societies. It happens in the world. This is not the end of society. In a year and a half, we're going to basically be back to normal. We just have to focus on the end game, not what we're in right now.
First of all, I say this to everybody. How are you? I hope everybody's healthy and happy. Okay.
Yeah.
You are in Chicago, correct?
That is correct.
What is the state of Chicago these days?
Chicago is doing okay. You know, I look out my window. I actually am able to see Lakeshore Drive. There's very little traffic. There's very few people out there. I think we're doing pretty well sheltering in place. We're going to see what happens to the healthcare system here. It's not like New York yet, but it's going to get worse here. So we're going to see.
So, Alex, thank you for coming on. I just want to, for our audience, you're a doctor, you're a physician. You were a general internist and former director of primary care at the University of Chicago. I think you're now in private practice. Is that right?
That's right.
Okay. The CEO of Imagine MD.
That's
so
right.
I wanted to have you on because you got a unique perspective. One, being on the front lines in practice as a physician, and then with your medical background, certainly would love your opinion as to what's going on now and where you think we're headed, that kind of thing, from the standpoint of the coronavirus. So first of all, New York seems to be kind of the epicenter of this country. Would that be accurate?
That's right. Right now, the most number of cases, the highest density of cases is in New York, yes.
Now, Chicago is a dense city, but it's a bit more spread out. I'm just wondering, is that pretty much the difference between the two as to the spread of the virus?
I don't think so. I think it was bad luck. I mean, New York is a higher population, so there was a greater likelihood that index cases would be there first, and it just happened to be that way. I mean, remember, there's also Washington State and the West Coast.
Yes.
But once you have an index patient, the density of the population, the interaction that people have on a daily basis, the way the virus spreads, all have contributed to making New York right now the epicenter. But all big cities are at the same risk. And Chicago had the advantage of two things. One is it happened in New York first, so we could see it there. And we have leadership here that listens to scientists and took decisive action earlier, I think, in the course than New York did, because they were caught earlier in the entire involvement of COVID-19 in the United States. And there was a slowness to recognize the importance of sheltering in place early.
Yeah, I did see in just recently some health leadership, and also I think the mayor say, go about your business. You know, when this thing was hitting, the only at-risk population is the older, so, which surprised me. From your perspective as a physician, have you treated anybody with the virus?
I have. I have some patients, both who I think have it, who have not been able to be tested, and a few who have been tested and have it. Yes.
What is the treatment right now outside of what's in development coming down the pike?
Yeah, there is currently no treatment other than supportive treatment. So think of the coronavirus just like any other respiratory virus. What do you do for those? We don't have medicines other than perhaps one, which we can talk about, that actually interfere with the natural history of a viral respiratory infection, meaning that once you get it, your immune system has to take care of it for you. And when we're talking about regular old respiratory viruses like respiratory syncytial virus or adenovirus, these are minor viruses that don't kill people or very rarely kill people. We don't worry much about it. We just treat the symptoms. Well, the same thing is true for COVID-19. We really mostly can only treat the symptoms, and only when people get severely ill with pneumonia do we admit them to the hospital, and then even then the care is supportive, meaning if their pneumonia starts to get severe and they can't oxygenate their blood well, we put them on ventilators to improve the oxygenation, but it's still a person's own immune system that has to get them through the virus.
So you're treating them like any other respiratory issue right now?
Yeah, the real answer is there's almost nothing we can do. We recommend Tylenol or Advil for the fevers, chills, and body aches that for many people are quite severe, and rest. And that's basically it.
So let's talk about that. I have heard conflicting things about Advil or anti-inflammatories.
Mm-hmm. Yeah.
They're fine.
There's currently zero evidence that they have any impact negatively or positively on the course of coronavirus whatsoever. There was a theoretical reason for why people thought maybe we shouldn't give them and some anecdotal reports, but if there's any one theme that I want to emphasize here, it's that anecdotal reports are useless. And so there's currently no evidence whatsoever and no reason to recommend against taking ibuprofen for this. Advil slash ibuprofen is generally more effective for fever-related symptoms, the fever itself, body aches, chills, than Tylenol. Some people do very well with Tylenol, and they can certainly try that first, but there's no reason to fear ibuprofen in this pandemic yet at all.
So are there distinctive markers from either a symptom or something else of knowing at this point whether you're just getting a cold, flu versus coronavirus?
There is only one or two symptoms that are appearing to become or beginning to look as though they may be unique to coronavirus, but they cannot be relied upon. So the general answer to your question is no. Based on clinical symptoms, there's no way to tell until you get very sick, in which case, when you get actually short of breath and develop viral pneumonia in this setting with a pandemic, it's almost certainly coronavirus. The two symptoms, though, that are beginning to emerge as being unique to coronavirus are actually decrease or loss of sense of smell and loss of sense of taste. Currently, this is anecdotal. I have yet to see a study that quantitates this, but it's starting to be heard enough that I think it's probably real. So if you start to have upper respiratory tract symptoms like a sore throat, which is seen, headache, maybe a stuffy nose, although that's less likely, and you do not smell or taste well, you probably have COVID-19. But other than that, you really cannot, until the severe or late stages of the disease, you cannot reliably diagnose it from the clinical picture. Although the clinical picture is unusual compared to other usual respiratory viruses. And by that I mean usually less severe respiratory viruses, the ones we're used to. What happens typically is the first day or two at most, you have low-grade fevers, so maybe 100, 100.5. And very quickly, the symptoms that predominate are related to the respiratory tract. So stuffy nose, runny nose, sore throat, ear pain, maybe a cough. And the fever goes away very quickly, and then you're left with those other symptoms that often hang out in one body cavity for a while, and as they get better, then it moves to another. So, for example, as the sore throat and runny nose gets better, then you start coughing. And the average length of time that upper respiratory tract, or I should say a respiratory virus lasts is actually 3 weeks. But you're not nearly as sick as people can get with coronavirus. Now, with coronavirus, the picture is different. Typically, the first 4 to 5 days, you may be achy and chills. You may have a little respiratory stuff in the upper tract. And then around day 5, you start to develop fevers. The fever seems to be delayed. And it lasts longer. It can last 5 to 7 days. So if that's the picture, then you're already probably not dealing with a usual respiratory infection, but you probably have COVID-19.
I can't imagine how many times you've gone through this with people. I mean, I'm assuming you would love to tape it and just play it every time you see somebody.
I don't know if you saw, but I have been putting up a series of posts on my blog where I'm describing all of this and backing up with the scientific papers that I am reading and my analysis of those papers. So certainly anyone who's listening who wants to get an in-depth view directly from the science that's being published itself, you can go to my blog, which is at www.imaginemd.net, and click on blog, and you'll see them there.
By the way, I want to thank you for your service and everything you're doing. So back to what we were talking about, symptoms and what have you. Diarrhea?
Yes. We're seeing diarrhea. We're seeing gastrointestinal symptoms. The virus clearly is what we call tropic for the GI tract, meaning it likes the gastrointestinal tract. We are finding RNA, viral RNA in stools. And so it definitely, a number of people are in fact presenting with GI symptoms. It can be nausea and vomiting. Diarrhea is more predominant, but for sure that is a symptom.
It seems like I'm seeing that it really, really varies as to, it's on a continuum. There's some people that have the virus but are not very sick, and then some get very, very sick. It's like anything else. It falls on a continuum based on the person's health or the state of their immune system.
That's exactly right. What's fascinating about this virus is that unlike most other viruses, including influenza, the continuum of clinical illness is hugely varied. So there's a lot of talk about asymptomatic people testing positive for the virus and not developing symptoms. That's probably the minority of people. But the majority of people, they get what looks like a cold and and a bronchitis. And about 80% of people have what looks like a regular old viral bronchitis, viral infection, where they're clearly sick, but not horribly so, and they recover and they do fine. But 20% of people get far sicker. And of those, maybe 15%, 10 to 15% are sick enough to require hospitalization. And so it's fascinating how this virus has a really wide degree of severity in different people. And the reasons for that are undoubtedly varied. Number one, of course, the host. So the person who's infected will bring different things to the table. Age, and therefore somehow immune response is going to be a huge impact. Other underlying diseases that may or may not be present are clearly having a huge impact. But also, there's this idea about the initial viral load. So in animal models, when we see, for example, in the mice model of influenza, when experimenters hit mice with a huge viral load, meaning a huge concentration of influenza virus, the mice get much sicker. And when they give them a lower load, they still get sick, but not as severely ill. And there's a couple other animal models. Hepatitis B is another model where the initial concentration of virus seems to impact the severity of illness. So it's been hypothesized that one of the reasons, for example, healthcare workers seem to be not just more frequently ill, but possibly more severely ill, is because the viral loads they're exposed to are much more concentrated than many people out in public, right? So if you're intubating, meaning putting a patient on a mechanical ventilator, the thought of the concentration of virus spewed into the air around which these physicians are breathing is much higher. So this is a theory. We don't know it's true for sure in humans, and we don't know if it's true for sure in humans with COVID-19, but it might be another factor that explains some of the variation in severity of clinical course.
So it could be a couple of factors. One is the health state of the person who contracts the virus, but also just the total load of the virus they're exposed to.
Yeah, we know the first for sure. In most viruses, like influenza, it's the very young and the very old who do most poorly. We don't know why with this virus, coronavirus, that the young are relatively spared. That's wonderful, but we don't know why. That's for sure. The viral load is more a hypothesis at this point that we don't know.
Oh, got it. Okay.
Most people have what seems like a run-of-the-mill infection. The difference is that's not what's being highlighted in the news. So people have this misperception that if you get this, you're going to become deathly ill. That is the rare exception. So this is really important. And this gets to maybe the psychological aspect of the effect of this pandemic. If you look at the actual statistics, 80% of people have what's just like a run-of-the-mill respiratory viral infection, which can be pretty lousy, and you can feel pretty bad and cough pretty hard and not be happy about it, but not be by any means non-functional at all. That's the majority of cases. In 20% of cases, it's more severe. Maybe those people need to be admitted to the hospital. Of those, maybe 10 to 15% are really, really sick.
So why are we all in our homes with stay-at-home orders?
So first of all, COVID-19, the virus that causes it, which is SARS-CoV-2, is far more transmissible and infectious than influenza. And that's partly because the incubation period is longer, because there may not be more asymptomatic spread, but it is the incidence of the disease in populations is far higher. So the second reason is because even though this number is probably not accurate, it's going to change as we get more data, the case fatality rate, meaning the percentage of people who die from this, is also much higher. The best estimates is that it's 10 times higher than influenza. Now that may change because, especially in America, we're under testing, and so we don't know the total number of true cases, which is undoubtedly much larger than we're recognizing, which means that the total number of deaths divided by that number is a smaller number than we currently think.
The denominator is larger.
Correct. The denominator we're underestimating the denominator. But if this virus is as more infective than influenza as we think, that means the total number of people, the absolute number of people that will be infected, will likely be far greater than that of influenza. So even if the overall case fatality rate is, say, 1%, It might end up being somewhere right around there.
Is that what you think it is right now?
Well, it varies by age. Right
Okay.
now, in the age range that I'm in, 50 to 60, or 50 to 59, the case fatality rate is 1.3%.
It's
And
10% for those 80, or I think I saw. Or something like that.
80 plus, it's about 18%. But the other way to think of that about that, by the way, is so if you're 80 years old and you get it, you have a 72% chance of surviving it. But let's just say, I'm just for sake of argument, I really don't know that no one knows what the real number is, right? So there's 325 million people in America. Let's say conservatively, 50% of them become infected. So let's call that 170 million people. 1% of 170 million people is 1.7 million people dying from this, right? That's not a small number. That's a huge number. To put that in perspective, in a bad flu season, 80,000 people die from flu every year. So to get back to your original question, why are we socially distancing ourselves? It's not because that's going to ultimately affect the total number of people infected. Socially distancing ourselves will do nothing to bring down the total number of people infected, because ultimately we're going to all have to come out. We can't maintain this for many reasons that are obvious. What it does is it slows the rate of rise of new cases. And it's just what you said. That enables the healthcare system to try to keep up. Our healthcare system typically works pretty close to capacity. We don't have a lot of excess ICU beds.
Maybe one good thing is that reveal. I certainly didn't know that was the case.
No, most people don't realize that. So we have almost no excess capacity whatsoever. So it does not take very much to overwhelm the healthcare system at all. And so if there's going to be 1.7 million deaths, if that number of people get sick within the space of even 2 months, it's going to be much higher, because a lot of people will die who wouldn't have died had they had access to a ventilator. So it's those people's lives we are attempting to save by sheltering in place.
Could there have been, and can there be, some form of segmentation where, okay, if you're 70 above, you are quarantined. If you're a business, no more than 10 people gathering? Or was there any form of parsing that could have been done earlier? Or is the extreme measures we're taking now catch up, or both?
No, and I'll tell you why not. Not every pandemic is different. Every infectious agent is different. We have only recently figured out that young people have a lower risk of death from this. And so at what point did we know that? And could we have changed our plans? Possibly. But, the organization from our leadership at the national level has been abysmal. There were supposed to have been pandemic plans at the CDC. I never really saw those. I think we're playing catch up to a great extent. I think that there's a dramatic lack of coordination at a national level to tell us what we should be doing. And the other issue, of course, is that even if you just had elderly people shelter in place, young people who are less likely to die from this, if they aren't sheltering in place, they'd be more likely to catch it and give it to those older people who inevitably they would have to contact in some way. So unfortunately, the answer probably always was that everyone needed to do this. And again, it's really because of the bottleneck being in our healthcare system. I mean, if we had an infinite supply of ventilators and doctors to man them and nurses to care for the patients in them, we wouldn't have had to do this, because all the people who are going to get sick, who are destined to get sick and need those ventilators, would get them. But we don't have that capacity. So by trying to spread it out, we're giving people who otherwise wouldn't have had access to those ventilators a chance.
Had we had the capacity, would there have been less need for the social distancing?
Yeah, because we're not going to have a vaccine for at least a year and a half. And so the social distancing, again, it's not to limit the total number of cases we're going to see. It's to delay the rate at which we see them.
It flattens that curve.
That's right.
So in the fiscal stimulus and all of the money the government's throwing at this lately, is any of it going to the healthcare system to increase capacity for any kind of next pandemic or next round of this?
I don't know that for sure, but I don't think that, I mean, my hope, if there's any silver lining in all of this, is just like with terrorism, which was presaged by at least 10 years before 9/11, but not attended to. It takes a devastating effect in a generation to wake up and actually prepare for the next one, right? So now we're prepared for terrorism in a way we never were before 9/11. I'm hoping that we will be prepared for the next pandemic in a way we haven't been, because one thing that people are not realizing, a pandemic was absolutely inevitable. There's no possible way this was not going to happen at some point. They always happen in populations. The worry was, how deadly was it going to be? And in terms of how deadly this one could have been, we're not anywhere near that. What if the mortality rate of this illness was 50%? The world would be very different right now. And I'm hoping that we will learn our lesson and pour the appropriate resources into pandemic planning and get ourselves educated and know what to do next time, because the next one might be a lot worse.
So let's say I get a little bit of fever, or I'm a little sick. At what point do I need to go to the hospital or go to a clinic or something?
You should only go to seek medical attention if you become short of breath. Most people will not.
So I'm bedridden, I got a high fever, I just don't feel great, but I'm not short of breath, but I feel like shit.
Right.
But don't go.
Nope.
Okay.
Nope.
Okay.
There's nothing they're going to do for you. They're not going to miss you. Just take Tylenol, ibuprofen to make yourself feel better. You got to wait it out. If you start getting short of breath, it's a different story.
So is there any other either myths or things that are out there that we haven't covered?
Yeah, a couple of important ones. First of all the hype around hydroxychloroquine and azithromycin is utterly unwarranted. The studies that we've seen so far were crap. And the one study, which was poorly designed, did not even have as an endpoint the clinical improvement or reduction in mortality. All it did was look at the rate at which the virus is no longer detectable in the mouth, which is an endpoint that no one cares about, at least not in terms of interfering with the natural history of this disease. So what's happened, unfortunately, is because the president has made this,
Is this the malaria drug?
Okay. Yeah. The brand name is Plaquenil. There is no good evidence whatsoever that this does anything to help people with this disease. There are real risks to this medicine. This medicine also is desperately needed by people for whom it has been proven to work, which are people who have things like rheumatoid arthritis or lupus, who can now not get it. So one of the big dangers here is that the lay public does not understand how to evaluate paper scientifically and is putting their faith in political leaders who are not listening to scientists. We are doing the proper trials to figure out what drugs, if any, may impact the disease. We do not have any currently that do. People should not expect that we're going to for at least another month or two. That's the first thing. The second thing is this big question about whether or not the virus hangs in the air. So there was a study that came out that everybody interpreted to mean as though the virus hangs in the air for 3 hours. This study was widely misinterpreted. The reason the virus hung in the air for 3 hours is because a device was used called a Goldberg tube that actually is designed to make viruses hang in the air. And the reason it hung in the air for 3 hours is because that's how long they left the device on. What they were trying to figure out was when the virus is aerosolized, meaning in the air, how long is it viable? And that was the question. It did not seek to answer the question, how long does the virus hang in the air when someone breathes or talks or coughs or sneezes? We do not know the answer to those questions. There is some data from influenza to suggest that when people do cough, that particles could be ejected in the air far greater than 6 feet. It can go up as far as 27 feet. But we don't know at what distance that concentration decreases to the point where it can no longer infect you. So there is airborne transmission. It does hang in the air to some degree. It's just not clear where that risk is. So I just want to debunk the myth that we know it hangs in the air.
Should we all be wearing masks?
That's a big question. So let me answer that one. The answer is the masks that we all have access to will not protect us from becoming sick if someone coughs on us or breathes on us with a large enough inoculum of virus. It will, however, likely decrease the risk of us making others sick if we cough or breathe or talk while we're wearing a mask. And since we don't actually know to what degree the virus is spread into the air in an infectious way when we do those things, it is entirely reasonable or out in public to wear masks.
You said there's a load too.
Yeah, the load is not likely going to be much mitigated by
All right.
wearing the types of masks that we have access to. The N95 respirators, when worn correctly, will prevent you from inhaling viral particles. But even doctors who are trained and test fitted, 65% of the time are not achieving a good seal. So for the lay public who even gets a hold of those N95 masks, the likelihood they're going to use them correctly enough to get a good seal to protect themselves is pretty low. But I do think it is worth us all to protect one another, not to protect ourselves, wearing masks when we go out, and we're going to be, with people closer than 6 feet. So because those of us who are asymptomatic Some of us have it. Now, from the data I've seen, I'm not convinced it's that high a percentage. So the risk of us spreading it when we're having no symptoms to others when we're socially distancing ourselves, I think is actually still kind of low. So I'm plus minus in the mask wearing in public. I think better safe than sorry is a reasonable way to go, but it's not to protect ourselves. It's to protect people from us.
I get deliveries from Amazon and sometimes food deliveries, and I'm kind of wiping the stuff down. What's the shelf life of the virus on things like plastic and cardboard and
So
boxes?
plastic and metal, it lasts the longest, 3 days before it becomes undetectable. But during that time, it is rapidly denaturing. Cardboard is about 24 hours. So if you get a delivery, you can either wait a day before you touch the box, or you can wipe it down with Lysol or disinfectant wipe and be safe. I would do one of those two things with your delivery.
Okay. One more thing. I actually wrote it down here. I forgot to ask you. Can you educate us on herd immunity? So is there a true evolutionary phenomenon that incorporates the concept of herd immunity versus somebody using it as a short-term inoculation strategy?
Yeah, so like I think Britain was thinking about using letting people catch it to develop herd immunity as a strategy. The problem is the virus kills too many people to do that. Why don't we shelter in place from the common cold? Because it doesn't kill people. Herd immunity can be developed basically in two ways. One is through vaccination. The other is through people actually getting the disease and becoming immune to it. And depending on the disease, and this is not my area, so I need to be careful here, but what I understand is that around when 80% of a population develops immunity through one of those two mechanisms to an infection, it becomes hard for that infection to continue circulating and it tends to die out. But it's also infection dependent. And so, like MERS, which was, it's another coronavirus, far more deadly than the current one. That died out because the incubation period was short, so the ability to transmit it in an asymptomatic stage was limited, even though the mortality was much higher. And so it died out because we didn't have to develop herd immunity for that to go away because we could identify cases, isolate them, and prevent them from spreading it. So with this disease, though, I've seen some estimates that about 80% of the population would need to become immune for it to stop circulating. The truth is, what's probably going to happen is it's now going to become something that's just with us. It's going to be a human pathogen that people have. The rate of infection will dramatically die out as more and more people become immune to it, but it's probably never going to go away.
So it's April, the weather's warming. Is that going to help?
No one knows, but probably not. In warmer climates that it's already there, it doesn't seem to be slowing the spread. That's wishful thinking, I think, probably.
So for the majority of us, and outside of those who are very sick, but the rest of us are suffering, right? We're social creatures from a standpoint of evolution, and now we have to isolate ourselves from, in some cases, those people that we love, or in some cases, family. So that's one. Add to it, some people have lost their jobs, or at least temporarily, or not sure what's going to happen with their work or their roles in this world when this ends or dissipates or what have you. So there's probably a great deal of stress. And I was just talking to some people, and I always ask people how they're doing and what have you. And someone told me, he said, I'm oddly calm, but I think it's because I'm not in this alone. Everybody has to do what I'm doing. Now, everybody has their own individual issues or problems and stressors, but I just thought that was an interesting take, because we all, from a standpoint of what's good, we're in the same boat, we're sharing this experience, but it is a difficult experience. So there are certain physical practices to stay healthy regarding a virus like this. What practices can we talk about that we can use to stay emotionally kind of stable?
The first thing I think is to recognize what is the source of the anxiety that most of us are feeling, or many of us are feeling. And it's very interesting for me because about 3 weeks ago when this started to tip, and we weren't hit yet in the United States, but it looked as though we were going to be. I had a number of patients look at me and say, this isn't that big a deal, right? And it's like flu, and most people don't get sick, and we're probably okay, right? And everyone was pretty sanguine about it. And then over the course of 2 days, Thursday and Friday, 2 weeks ago, I got 70 calls from people who began freaking out. And suddenly everyone is freaking out, and now we're sheltering in place. And what happened? Well, what happened was the news media became saturated with stories of COVID-19 and began showing us all the terrible things that it was doing. And so number one, it's top of mind for everybody because that's all we're reading about. Two, the flow and change of information is so quick. things are changing and there's new information every day that we all feel we have to keep paying attention. And so this is all we're thinking about. So it's on top of mind. It's hard not to ruminate about something that keeps being thrown in your face. And then we're hearing in the news about all the bad stories, right? We're hearing about the young people who are on ventilators, even though the actual percentage of that is extraordinarily small. We're hearing about celebrities dying from this, who we often feel like we know. And so it becomes very personal. And the real risk here is the risk of anecdotal thinking. By that I mean, and this is well established about how our psychology works, when you hear stories of things happening, bad things happening, and you can picture yourself in those stories, you overestimate the actual risk of those things happening to you. So for example, if you're going on a plane flight and you hear in the news of a plane crashing, emotionally you will respond to that with a belief that the likelihood of you crashing is higher. You'll be more worried about it than statistics suggest you should be. Well, I think that's happening in a major way now. And so all we're hearing about are all these people getting it and getting sick and dying from it. And we're thinking anecdotally. We're listening to stories and getting worked up by that. But if you really look at the statistics, and I published this in my latest blog post on the coronavirus, unless you are over 70, even over 60 people, the rate of dying from this is extremely low. Now, from a population perspective, we're still looking at potentially millions of people dying. But from an individual person's risk, if you yourself are facing a coronavirus infection, for most people, you have literally more than a 99% chance of surviving and being just fine. The statistics are that good. But we keep being diverted to the possibility that it's much worse by what we're seeing in the news. And so I think the very first thing to do for people to calm themselves down is to actually look at the statistics. And when they start to get worked up by a story that they hear, they start to find themselves reacting in an anxious way and maybe even affecting their behavior in a way that is driven by that anxiety, to take a breath and remind themselves of the statistics, because that's where the truth lies. And there are many things that we all do every day that give us a greater risk of death that we don't even think about than COVID-19. Getting in a car and driving in a busy city, smoking a cigarette, lots of things where the actual risk is higher of us dying than it is from COVID-19. So we have to think statistically. That's the first thing. The second thing is we actually need to stop thinking about this at all. We're in our homes. Many of us are not working, unfortunately. And even those of us who are working at a reduced capacity. We have more free time on our hands than before. It's hard not to ruminate about this because it's so front and center. The way to not think about something is not to try not to think about it. It's to find something else to think about that draws your attention more. So people are streaming movies, reading books, all those things. But now's the time, if there's a list of projects you had on your someday list, bring it out. Start doing it now. Be productive. Create something meaningful. Reach out to friends you haven't talked to in a while. Anything to distract yourself from thinking about COVID-19. I got to tell you, if there's one message I really want to hit home here, is that we are going to get through this. Pandemics happen in societies. It happens in the world. This is not the end of society. In a year and a half, and it might take that long, we're going to basically be back to normal. And this is going to be all in the rearview mirror, and most of us will be fine. I mean, depending on how many people ultimately die from this, we may all know someone who dies from this, which will be tragic. But most of us are going to be okay. And we just have to focus on the end game, not what we're in right now.
Is this going to go through the summer?
Yes.
Okay.
It's going to go through the summer. It's possible that we will bring people back in waves, perhaps as we discover through antibody tests that groups of people are immune and therefore go back to work. It may be that as the healthcare system catches up, as the cases start to decline, that we'll come out of quarantine and then it'll go back up again. There may be a number of waves of shelter in place, but there's no way we're getting back to normal before the end of the summer. And even that, I think, is going to be premature. The one thing that might change that is if we get really lucky and one of the medicines we're investigating to treat this works really well. That could be a game changer.
So the other day I went stir crazy, got on my bike, and it was very helpful, very peaceful, hardly anybody out. Went down this back roads. It was about a 10-mile round trip, but about a 5-mile one way. I went to a certain location where I came to this little downtown area, this small town. They're having a small, I don't know if it was a flea market or what, but it wasn't huge crowds, but there were people milling about. Should I freak out that I just ran into a pack of zombies and hightail it out of there? I don't know what to do sometimes.
You should avoid crowds. So if you see a crowd milling, don't go mill with them. The risk of you catching it from them is low as long as you're not in among them.
If I speed through with my bike, I'm fine, right?
Yeah, or go around if you can.
Okay. Alex, this has been great. Thank you so much for coming on. I appreciate it. By the way, give us your blog where you're doing these updates.
Yeah, so it's www.imaginemd, all one word, .net. That's our website. And then the blog is a link up at the top, and you can read all those posts that cover the science in a clear language that lay people can understand.
Great. And I'll post that as a resource in the show notes as well. Thank you very much.
Thank you.
Well, that's a wrap. Thank you for listening. If you enjoyed it, do share it with your friends and on your social platforms. Big thanks to Sam Williams, my audio guy, and the beautiful bumper music you're hearing is Michael Petrovich's Bella Luna. For all my show notes or resource links, visit LarryWeeks.com, and we will talk again soon.